On behalf of Department of Pulmonology, Yashoda Hospitals, Secunderabad, I invite you all for today's 14th South June Postgraduate CME in Pulmonology, being organized by our institute in association with the Indian Chest Society South June Chapter and Non-Pharmacological Division. At the outset, I would like to express my gratitude to all my doctor friends who have come all the way from different areas in spite of their busy schedules. All of us have had a tough time in fighting against COVID-19 pandemic, and my sincere compliments to the pulmonology fraternity who stood the test of time and worked hard in these unprecedented times to save the millions of COVID patients. For the last 18 months or so, we were just attending all the talks and CMEs and virtual platforms. But as the world started now coming to normalcy, we just planned to host this program as a completely the physical one and bring the flavor of conference and also academic benefits to the aspiring students. After taking the inputs from our seniors, a 1.5 day program is meticulously planned to bring the best in academics as much as possible. First day, that is today, it is totally allocated to the talks by the senior faculty who will take you through recent updates and trends in the field of pulmonology. On second day, that is tomorrow, the main focus would be on practical points, what an exam going student should need to be exposed to. There would be case discussions also tomorrow as well. You can interact with the faculty, you can get clarified all your doubts. I strongly believe this program will be much enlightening and you all will go home with enriched knowledge in pulmonary medicine. Thank you all once again and I wish you a happy learning experience. Thank you all and now.
See, when you enter pulmonology PG, there are few things which comes into your mind: asthma, COPD and tuberculosis. So we start there only. So our first talk would be on treatment of asthma. I request Dr. R. Vijay Kumar sir, National Faculty, to address the stage. Thank you.
Good morning. Dr. Pawan Gorukanti, Director, Yashoda Hospitals, the young, energetic, ambitious, and extremely affable person. My extremely dear colleague, Mallu Gangadhar Reddy, for the last 10 years and more, when I was here for 10 years, and a very wonderful friend. My fellow faculty and my dear postgraduate doctors. It's a pleasure to be here as a part of the 14th South Zone postgraduate meet of the Pulmonary Medicine, which is endorsed by the Indian Chest Society and very strongly supported by Sun Pharma. Asthma is the talk about which I will be spending about 17.5 minutes. We'll leave about 30 seconds for the questions if there are any. And we'll talk about, has anything changed in 2021 after the pandemic? So, just to put you on the rails, asthma is a major non-communicable disease affecting both children and adults across the world, not just our country. And as we know, inflammation of the mucosa is the primary pathology, which results in narrowing of the small airways. And I didn't know, I'm sure many of you did not know, that asthma is the most common chronic disease among children. And asthma-related deaths do occur in countries like ours, which are low and lower middle class or lower middle income countries, which is undertreated and also underdiagnosis, which is a challenge. So this is where all of us sitting in this hall have to take a pledge and then take care of our asthma patients. Crores of people do suffer from asthma across the world, and several lakhs do die of asthma every year. There was a time when I started practicing in 1977, people used to say, don't rush, asthmatics don't die, you can wait, they can wait. But it's not so. You can see that nearly 5 lakhs of people are dying every year because of asthma. So in the next few minutes, I would like to focus on 5 important areas. One, since we have just emerged from the second wave of the COVID pandemic, and we are on the cusp of the third wave anytime soon, somewhere in November of the first week, it is important to know how do asthmatics fare as far as COVID is concerned. Does it affect them more? Do they have much more severe disease? Do they die more? Let us see what happened. There was a beautiful meta-analysis by Wang from China, who looked at a lot of studies which have been published at that time, and then he found that there were 5 important studies with large number of people, 744 asthmatics to be precise, and he compared that with nearly 8,000 non-asthmatics. What he found was that there was no difference in the duration of hospital stay, and there was no difference in the duration of their ICU stay. And what is important to the patient, the family, and the doctor is that there was no difference in the mortality, whether he had asthma or no asthma. So I will show you the forest graph, which shows that whether he is asthmatic or a non-asthmatic, the ICU stay and the mortality remain the same. GINA guidelines, which has been released just a couple of months back, has some advice for the asthmatics with regards to the COVID-19. It says, get vaccinated, don't hesitate, and take all the precautions which everybody else takes, and do not stop your inhalers, especially the inhaled corticosteroids. Asthma visits were less, as all the pulmonologists would have noticed. The outpatients were less as far as the asthmatics were concerned, and less asthmatics were getting admitted in the hospital. So all of us know the reason why this reduction in asthma took place during the pandemic. Let's move on to the second area, and that would be really little unusual, that is pharmacogenomics. Pharmacogenomics, I am sure many of you are listening for the first time. What simply means is that we have been seeing patients, nearly 65% of them, their asthma is not under full control. And nearly 1/3 of the patients who are on inhaled corticosteroids may not have excellent results, and they do not achieve the objective improvements. Many may not respond to the leukotriene antagonists. You'll be surprised why. And 1/3 of the patients who are on the oral corticosteroids do develop osteoporosis. That means 2/3 do not develop osteoporosis despite they being on the steroids. And some patients develop inhaled corticosteroid related cataract. When I started writing inhaled corticosteroids way back in 1980s, there was one case which went to the L.V. Prasad Eye Institute, and the doctor wrote back, inhaled corticosteroid related cataract. I said, it cannot happen. They do not get into the blood. They are topical steroids. But they started the chain reaction, and then there were more and more cataract cases because of the inhaled corticosteroids. Only some develop, others do not develop. Why? Some patients have increased mortality because of the short-acting beta-2 agonist and also long-acting beta-2 agonist. Why some people escape? The answer for this is that 80% of the variability in response to the therapy may have a genetic basis. That means we are born in a different way from others. They respond differently and we respond differently. So this is all about the mechanisms that have heritable factors. And every step from the absorption, distribution, metabolism, and excretion, every step is under genomic control. So what has been done as far as the pharmacogenomics has been concerned? beta-2 adrenergic receptors gene has been sequenced thoroughly. Several genes involved in the regulation of the leukotriene systems and the synthesis and degradation were assessed completely, and inhaled corticosteroids have been studied in depth, and several genes have been identified as far as the receptors are concerned. But what is in it for us? Pharmacogenomic assays are going to be available in the next 5 years, and the cost of genotyping will fall. So clinical trials, those who want to do bronchial thermoplasty or those who want to do introduce the newer mepolizumabs, etc., they should obtain a genetic material because they need to know the genomic profile of the patient. Genotype studies and biologically informative studies should allow not only to do no harm to the patient, but also do much good to the patient. We move on to the third phase, and that is, there is a special group of asthmatics. Who are these people? These people are between 50 to 70 years of age. They are on the best treatment. They are on the best adherence of more than 80%. And they are using the highest dose of inhaled corticosteroids possible, that is 800 micrograms a day. And still, they had one exacerbation requiring oral corticosteroid at least once a year. What's wrong? We're doing everything right. So we need a solution. And the solution came in the form of the British guidelines. They said there is a drug which can change it. That is azithromycin, which was introduced in 1980. It's an excellent drug, widely researched. It is active orally, excellent tissue penetration, and it acts on gram positives, also some gram negatives, and some atypical organisms. But we are not talking about the microbiological efficacy of this drug. We are talking about the immunomodulation. It alters the airway secretions. It stops the ion transport, thereby reducing the mucus production, and alter the cytokine production, and also it can interfere with the action of the adhesion molecules, and also thereby reduce the inflammatory cells. It can disrupt the biofilms, and it reduces the bacterial adherence to the epithelial cells, and it can reduce the toxin production and also reduces the mobility of the bacteria within the respiratory tract. So azithromycin is a drug for that particular special category. The dose is 500 milligrams 3 times a week, to be given at least for 6 months to 12 months. And before you put your pen on the paper to write this medicine, there are 3 tests that you need to do. One is the ECG, where you look at the Q2 interval. That is, from the beginning of the QRS complex to the end of the T wave, you count the number of small squares and multiply that with 0.04. You get the Q2 interval, which should be 400 milliseconds. A leading cardiologist, Dr. Shashikant, is here. He would be able to clear your doubts about the QT intervals. LFT can get arranged on a long-term azithromycin. So you need to do a LFT periodically. Sputum culture is done just to see, since we are using an antibiotic for such a long time, there is any drug resistance. We move on to a very important phase, the 4th point. We are talking about short-acting beta-2 agonist. Let us look at the journey of short-acting beta-2 agonist. This was introduced when I was doing my MD during the 1977. And from that time onwards till now, almost 40 years, this short-acting beta-2 agonist is widely prescribed and widely misused by the patients as well. So soon after its introduction, we came to know that there were adverse reactions related to the short-acting beta-2 agonist, such as tachycardia, muscle tremors, muscle contractions, and it can also adversely impact the hypokalemia, especially when you use it with corticosteroids, some diuretics, and xanthine derivatives such as theophylline. And soon after, short-acting beta-2 agonist hit the market. When you trace the journey of short-acting beta-2 agonist, different researchers and authors came up with their observations. They said, short-acting beta-2 agonist use was associated with increased risk of death from asthma, especially if they use more than 2.6 canister a month. And the same person after 2 years said the risk of death increases dramatically after exceeding the usage of 1.4 canisters per month. And regular use of inhaled corticosteroids can stop this death if they are on the regular short-acting beta-2 agonist by 40%. Then smart therapy was introduced in 2006, but still short-acting beta-2 agonist was in the print in GINA guidelines. And over a period of nearly 17 years, they observed the behavior of the short-acting beta-2 agonist users. Asthma control was suboptimal in half of them, and severe exacerbation occurred in 44% of them, and nearly a quarter of them had to be hospitalized. Uncontrolled asthma in poor and resulted in poor quality of life, and healthcare costs went up. Survey in about 8 Asian countries taking exclusively rescue medication showed that only 15% of the patient had controlled asthma. So the new concept has arisen out of this. And what is that new concept? So the new concept is the management of intermittent and mild asthma. GINA guidelines in 2021 said we don't recognize between intermittent asthma, mild persistent asthma in mild asthma. So it's all one. Keep it as mild asthma. So epidemiologically, mild asthma is 50% of all asthmatics. Half of all asthmatics are having mild asthma. Just because we use the word mild asthma, don't take it for granted that it is mild. Severe exacerbations do occur in almost 1/3 of these patients requiring emergency consultations. Nearly 3/4 of the patients have to have acute asthma and near fatal asthma in mild asthma, because one doctor has said it is mild asthma, he neglected, and then he ended up in a fatal asthma. So the answer lies in using inhaled corticosteroids with long-acting beta-2 agonist. The choice simply goes to budesonide and formoterol combination. So what is the history of budesonide formoterol combination as needed concept? Long time ago, these authors in 2008, they published a lot of papers. And one author, Schurz, demonstrated by using different strengths of formoterol, 6, 12, 24, and then he found out that 6 micrograms is the best. It improves the peak expiratory flow rate in the morning and also in the evening. Then formoterol produced significantly lower heart rates, no tachycardia, unlike terbutaline. So it scored over terbutaline, the formoterol. Then in the emergency setting, they used short-acting beta-2 agonist at a very high dose of 3,600 micrograms and formoterol at a very low dose of 54 micrograms. Formoterol produced very good results. Budesonide formoterol was better than the other fluticasone salmeterol combination because it produced very rapid action. So it was wonderful. Budesonide formoterol combination was wonderful. Then they did a survey, and the survey was respiratory patient opinion survey. So it was called response survey. What did they find? The patients uniformly said, "Oh doctor, we don't want so many inhalers. One for rescue, one for maintenance, one is a combination, one is a single ingredient. We don't want such a confusion." Then what do you want? We want just one single inhaler which can take care of asthma. What were the other findings of this response survey? Majority of the patients want to use fewer medicines, want just one inhaler. 50% tend to rely on reliever medications. They want to use quick relief, so they keep using the short-acting beta-2 agonist. And they underuse the inhaled corticosteroids which hits at inflammation. 50% only adhere to the prescribed scheme of treatment. The doctor writes something, but they stick to only 50% of it. The others they ignore. People forget to take their inhalers. We forget to take our antibiotics. Instead of 5 days, we take it only for 3 days and then forget about it. It's a common human behavior. Patients are concerned about the side effects, so they don't want to use it. They decrease the dose on their own. They say, the doctor has prescribed a very high dose, let me use only half of it. And fixed dose inhaled corticosteroids in the form of budesonide formoterol addresses all these issues. There has been a debate between the short-acting beta-2 agonist and the combination of the inhaled corticosteroid budesonide. The pros and cons were discussed, and to cut the long story short, I would say the short-acting beta-2 agonists are good enough. They produce fast relief, easy to use, but treat only the symptoms, leaving behind the inflammation. Whereas the ICS formoterol, fast relief, also take care of the inflammatory part. So as a result, GINA guidelines has introduced inhaled corticosteroid formoterol from step 1 onwards. This is the earlier approach. The step 1 and step 2 contains only inhaled corticosteroids, and they said you use short-acting beta-2 agonists whenever the patient has a problem. So short-acting beta-2 agonists were introduced at every stage, but now all that has changed. Now you start with inhaled corticosteroids and formoterol combination and continue, keep increasing the dose depending upon the requirement, and never use short-acting beta-2 agonist. So there has been a lot of editorials written about this GINA guidelines, and they all agreed that this is a good step. So the last 2 slides is on the 5th area, that is the definition of severe asthma has changed. Now the new definition says asthma that remains uncontrolled despite high dose of ICS LABA is severe asthma. So they are not referring to the step 1, 2, 3, 4, etc. So irrespective of these steps, whenever the patient goes out of control, it is severe asthma. So friends, let me sum up my talk. Asthma treatment is getting simplified according to the GINA guidelines 2021. Mild asthma is serious business, mind you. It kills people. Mild asthma too needs ICS LABA. Dose of ICS LABA increases as per the severity of asthma. Patients like a single inhaler rather than having multiple inhalers in different pockets. Results and compliance are better with single device. Think of macrolides in a tough asthma. Macrolides are for a minimum period of 6 months. In future, treatment will be guided by pharmacogenomics and pharmacogenetics. Severe asthma definition has changed. Asthma that remains uncontrolled despite high dose of ICS LABA is severe asthma. Thank you very much. Questions I will be happy to take, if there are any.
Okay. Mike.
So one question, sir. Is it a broad group for macrolides or only azithromycin?
Yes, sir. They have studied all the macrolides. All the macrolides available, right from roxithromycin, clarithromycin, and azithromycin. They found that azithromycin has got these special immunomodulatory effects which others don't have. So that's the reason why they are banking upon azithromycin a lot, and they have clearly looked at the different dosages which works and which doesn't work. There are papers supporting 250 mg, 500 mg daily, alternatives, and 3 times in a week. And finally, they come up with this 3 times a week for 6 to 12 months. They said, keep an eye on the heart, don't always look at the lungs. once in a while refer the patient to the cardiologist.
The role of cerebroblast in asthma. Role of cerebroblast in asthma. Cerebro ATMG you used to write, sir, but
Yeah.
what is the role? I want to know, sir.
As per GINA, no role.
Thanks.
As pulmonologists, I think we have to set a standard for the practicing physicians, and whatever is not supported by evidence, whatever is not supported by proof, I think we should not support that particular drug.
Treatment. I request Dr. Vishwanath Gala, consultant interventional pulmonologist, AIG Hospital, Hyderabad, to present the topic. Thank you.
Respected seniors, dear colleagues, and postgraduates, warm wishes and regards from our team at AIG. At the outset, I would like to thank Dr. Gangadhar Reddy and the entire organizing team for giving me this opportunity to talk on severe asthma phenotypes and treatment. So my talk has been made very simple because of the introduction of asthma by Dr. Vijay Kumar in a very detailed manner about the recent changes. So I'll be talking on how to approach patients of severe asthma. So as Dr. Vijay has told us that SMART therapy, the single maintenance and reliever therapy, has been the main change in the GINA guidelines in 2020 and 2021. So whenever we see a patient with persistent symptoms, I would like to switch them to a single maintenance and reliever therapy which contains the inhaled corticosteroids and the LABA, which are usually of budesonide and the formoterol. Most of the patients, around 90% of the patients, their asthma gets controlled with this kind of step-up or step-down approach. There are approximately 5 to 10% of the patients whose disease remains uncontrolled and severe despite appropriate treatment. These are the patients in which we need to understand what is the basic pathophysiological mechanism leading to severe disease and then target that specific pathway or the specific inflammatory pathway. So this is where the concept of phenotyping comes in. So as Dr. Vijay has told us, this asthma which remains uncontrolled despite treatment with high-dose inhaled corticosteroids and other controller medications, or that requires such treatment to remain well controlled. Most of these patients, when you see them in the clinic, they are already on high doses of inhaled corticosteroid, budesonide, long-acting anti-muscarinic agents like tiotropium. Most of these patients are on montelukast. So their disease is either uncontrolled, or if the disease is controlled, but however when you reduce the intensity of the treatment, their symptoms worsen again. So whenever you encounter a patient with severe asthma, first try to change the approach to SMART therapy and also assess whether they're on high doses of inhaled corticosteroids or not. This is a table from GINA which tells us about the different doses of the inhaled corticosteroids. The common inhaled corticosteroid, budesonide, which is used, the maximum dose mentioned is 800. However, in the ATS and the ERS guidelines, the dosing of budesonide for high dose is around 1600. In our clinical practice too, most often we would keep the patient on at least formoterol budesonide of 2 puff 3 times to 4 times a day, which would come up to 1600 microgram. So assess whether a patient is really on high dose inhaled corticosteroids or not. And then after that, when you decide that really the patient is having a severe asthma, then you need to take this 5-step approach. And it's also important to understand that whether patient is having a really severe asthma in spite of the best treatment, or whether it is because of the compliance and adherence issues. So whenever you see a patient with severe asthma, one is to review the diagnosis of asthma, and look for alternative differential diagnosis, check for the complaints and the technique how they are taking the inhaler device or the tripod or device, look for ongoing exposures and treat the comorbidities, and also look at what is the type of severe, like phenotype of the severe asthma, and then choose the appropriate treatment choice from the armamentarium which is available. Let us understand what is like phenotyping and also each of these steps in detail. So the step one, when it comes to that, you all know that sometimes congestive heart failure can present like asthma, bronchiectasis, upper airway obstruction, foreign bodies, all these can mimic like asthma. It's a popular saying that all that pleases is not asthma. So look for clinical features which suggest other alternative diagnoses like murmurs, gallop rhythms, clubbing, which can go in favor of other alternative diagnoses like congestive heart failure. Sometimes we have seen patients with the tuberculosis being treated like asthma, especially the ones who have got endobronchial tuberculosis. They come with wheezing. So look for all these alternative differential diagnoses and also do additional diagnostic tests to look for this alternative diagnosis. And then also in the second step, you look whether the patient is really adherent to the treatment and using the correct technique or not. So there was a meta-analysis from Cochrane which looked at different steps which can improve the adherence of the patient to the treatment. It was found that educating the patients for at least 30 seconds to 1 minute will improve the adherence by 20%. And again, use of the smart inhalers, reminders, and a simplified regimen like what Sir has told, a single inhaler versus dual inhaler. All these simplified the treatment and also improve the adherence to treatment. And also sometimes the patient says that we are taking the inhaler in a like proper manner, good compliance is there, but if you check their inhaler technique, that will be wrong. 80% of the patients, when asked about the technique of inhaler, they are very, very confident. But it was studied that only 20% of these 80% will have a correct technique when clearly defined. So we are not, this was a study conducted in Canada actually. We are not different from other nations. So in our population also we need to check the inhaler technique and the compliance of the thing. And also look for other comorbidities and ongoing allergen exposures. I would like to say that a chronic rhinosinusitis is an important risk factor. Treat these patients with an inhaled nasal sprays which contains corticosteroids, and address obesity, ask them to lose weight. And we have seen in our patients in our clinical practice that losing around 10% of weight leads to significant improvement in obese asthmatic patients. Look for OSA and treat that. And also it was found that 30 to 40% of the patients with severe asthma have smoking as a risk factor. So address smoking cessation, advise smoking cessation for these patients. And these are the therapeutic. If you have come to a conclusion that it is definitely severe asthma, you have addressed the differential diagnosis, you have looked at the inhaler technique, compliance, and all these things. These are the options which are available for us for treatment of the severe asthma. One is the tiotropium, methylxanthines, macrolide therapy, biologicals, and bronchial thermoplasty. So Dr. Vijay has told us about the utility of the macrolide therapy in these patients, and tiotropium has also been shown to be beneficial in patients who have severe uncontrolled asthma with severe exacerbations. So to understand which of these agents to be used, whether it's biologicals, tiotropium, or the macrolide therapy, or the thermoplasty, we need to understand the concept of phenotyping. So phenotype means a recognizable cluster of either a demographic, clinical, or pathophysiological characteristics actually. So we have very well known from our MBBS days about this allergic asthma, non-allergic asthma, late onset asthma, and asthma with persistent airflow obstruction. So all these are people with certain set of characteristics. So this is about the clinical presentation and the phenotypes actually. So similar to these phenotypic presentation, clinical presentations, we have different pathophysiological mechanisms. Some people will have eosinophilic asthma, and some people will have kind of allergic or raised IgE with severe asthma. So the concept of this phenotyping and this endotyping means to identify what is the specific inflammatory pathway which is involved in the patient's, which is involved in the mechanism of the severe asthma. So 3 different studies have been conducted in Europe, United States, and like Australia. where they have looked at this phenotyping. This was a project which started in 2000, where they looked into what was the reason for the severe asthma and what are the inflammatory pathways. In these 3 studies, the SARP, which is the Severe Asthma Research Program, and the other thing is the asthma disease endotyping for personalized therapies, that is the ADEPT, and the U-BioPred. So they have looked at thousands of patients and have come up with some phenotypes. These are some of the clinical phenotypes which we commonly see in our regular practice. But however, these phenotypes actually don't guide us in treatment. 80 to 90% of the patients do respond with the regular step up or step down approach. We don't have to do any kind of phenotyping. However, if a patient's disease is uncontrolled and severe, despite all these things, then you need to find phenotype. So some of the phenotypes which are described in this study were the eosinophilic phenotypes. One phenotype is the patients with increased neutrophils, and some patients have both increased eosinophils and the neutrophils, and some patients did not have granulocytes, which is called as a paucigranulocytopenia. So why should we phenotype? So this is a very important cartoon from New England Journal of Medicine, which tells us the different inflammatory pathways. If you look at the allergic pathway of asthma, it is said that the Th2 type of helper lymphocytes play a very, very important role, and this stimulates the epithelium. When the antigen encounters the epithelium, it stimulates the epithelium to release TSLP, which is called as a thymic stromal lymphopoietin. This is important. I'm going to tell a drug which can target this TSLP. And then once this TSLP is released, it leads to stimulation of either the Th2 cells, Th2 helper lymphocytes, or the innate lymphoid cells. The cascade starts there, and there is release of further cytokines like IL-4, IL-5, and IL-13. IL-4 and 13 stimulates the B cells to produce circulating immunoglobulin, which again goes and binds to the mast cells. Whenever there is an anti-allergen exposure, so asthmatic patients, basically there will be mast cell release leading to histamine and other inflammatory markers, which we have read it in our pathology. Okay, and the other marker which is released, the IL-5, which is the interleukin-5, which binds to the eosinophils with an IL-5 receptor, and again it leads to maturation of the eosinophils and then also eosinophilic inflammation, and it also prevents apoptosis of the eosinophils. There is another pathway which is called as the non-type 2 inflammation, where research is going on and where different biologicals may be available in the next 4 to 5 years for patients with non-type 2 asthma. So as of now, the asthma understanding is that you have patients with a Th2 type of phenotype, or you have a patients with non-Th2 type of phenotype. So it's not simple to do IL-4, IL-5 and IL-13 for all these kind of patients. So there should be some markers or surrogates which can tell us whether the patient is having a Th2 type of asthma or whether a patient is having a non-Th2 type of asthma. So the surrogates in our clinical practice for Th2 type of phenotype are having an IgE which is more than 100, a FeNO, that is fractional exhaled nitric oxide, which is more than 30 parts per billion, or a blood eosinophils more than 300, or sputum eosinophilia more than 2%. If any of this is there, then we can say that the patient is having an Th2 type of inflammation. This is an important algorithm from European Respiratory Journal, Respiratory Society Journal. So if a patient has got an IgE predominant elevation, which is called as an allergic predominance, you have omalizumab. If you have like eosinophilic predominance, you have anti-IL-5 therapies, mepolizumab or benralizumab, which are approved in India. So if you have allergic or eosinophilic overlap, then you can either use omalizumab or mepolizumab. And also look for alternative diagnosis like allergic bronchopulmonary aspergillosis, where the treatment is going to be a 4 to 5 month duration of oral corticosteroids. And again, if you have come to a conclusion that it's a 2H2 type of asthma, again this is table which tells us whether it is an allergic predominant asthma where the IgE is making a predominant role, or whether it is an eosinophil predominant asthma. So in IgE, like predominant allergic asthma, you have IgE which is more than 100, and whereas in eosinophil predominant asthma, you have blood eosinophils which are more than 300 with a very high eosinophil FeNO which is more than 50. And this is the algorithm for T2 low type of asthma, where again you have either neutrophilic asthma where you can use macrolides, long-acting antimuscarinic agents like tiotropium, or you have phenotypes like paucigranulocytic where no like white cell like granulocyte, neutrophil, eosinophil, nothing is there actually. So, and again also here basically when you have a patient with neutrophilic asthma, try to address the obesity and advise them weight loss, which helps in their asthma control. So this is an important cartoon which tells us where all these molecules are going to act. When you look at this IL-5, actually when it's released from the Th2 cells, it binds to the IL-5 receptor. So certain molecules like mepolizumab and reslizumab directly bind to the circulating IL-5 and prevent their binding to the eosinophil. And there are certain monoclonal antibodies like benralizumab which will bind to the IL-5 receptor and induce the apoptosis of the eosinophils. And again, I've told you about the omalizumab. So omalizumab binds to the circulating IgE which is released from the B cells and decreases the asthma severity and exacerbations. I've told you about the anti-thymic stromal lymphopoietin protein. So there is one monoclonal antibody which is called as a tezepelumab. A very good study has been published this year in the New England Journal of Medicine on the efficacy of a positive efficacy of this molecule. This is not still approved in India, but I think in the next 1 or 2 years we'll be getting this molecule in India. So let us look at in brief about each of these molecules, about Th2 allergic asthma and omalizumab. So this was the first molecule which was introduced into the severe asthma armamentarium, and there's been wealth of evidence which was generated on the use of omalizumab. All the evidence pointed to that there will be decrease in the exacerbations, hospitalizations, quality of life, very good symptom control, improvement in the lung function, FEV1, and the decrease in the rescue medicine usage, and the decrease in the usage of the inhaled corticosteroids and oral corticosteroid usage. Now let us go to the second molecule, second type of molecules which are useful in the eosinophilic asthma, which are the anti-IL-5 therapies. So as I've told you that eosinophil plays an important part in the inflammation in asthma patients, especially in the eosinophilic asthma patients who have a eosinophil count which is more than 300. So it leads to inflammation by releasing various cytokines and chemokines. It also has various non-immune functions, interacts with many other cells, and also leads to narrowing of the airways with bronchospasm and mucus plug inflammation. So when you use any kind of anti-eosinophil therapies, these patients actually they have improvement in the quality of life, their exacerbations reduced. So clinically, when a patient is coming to us, how do you identify whether a patient is having a eosinophilic type of asthma? Some of the clinical phenotypes are basically you can have frequent exacerbations, low lung function, oral steroid responsiveness, and patients with comorbid chronic rhinosinusitis and nasal polyps. Most of the times from the peripheral blood picture, you know that this patient is having an eosinophilia, but there are certain patients where there is no peripheral blood eosinophilia. However, they have a pulmonary eosinophilia. So only if you get to know about the sputum eosinophilia, then you can tell that this patient is having an eosinophilic kind of asthma. However, the sputum eosinophilia is not a technique which is being practiced in most of the institutes. As a surrogate to that, we look at fractional exhaled nitric oxide levels, which is a marker of eosinophilic inflammation. So if you have any of these, then and any of these clinical features, then at least you can think that this patient might be having an eosinophilic kind of asthma. And in these patients, you have anti-IL-5 therapies. Two of them are directly binding to the IL-5 and neutralize them and prevent them from binding to the eosinophils. So the first one which was approved was the mepolizumab, and again there is a good evidence on mepolizumab from important randomized controlled studies which are published in New England Journal of Medicine, Mensa, and one is the Sirius. These both studies were published in 2017 and have shown that there is a significant decrease in the number of exacerbations in patients with severe asthma. There is decrease in the dosage of oral corticosteroid usage when the patients are using regularly for their severe asthma, and also it was found that there was some improvement in the FEV1 and the quality of life. And the next came the benralizumab. I will not be discussing about reslizumab, which is an IV anti-IL-5 agent, and it's mainly for IV usage actually. It's not been approved in India. So next anti-IL-5 therapy which is approved in India is the benralizumab, which is an anti-IL-5 receptor, and it should be used as an add-on therapy to the like step 5 GINA treatment in patients who have a severe asthma and severe eosinophilic asthma. It has got an induction and a maintenance phase where you give the first 3 doses at a duration of 4 weeks, and the next subsequent from 4th week onwards you give the dosage at the interval of 8 weeks. So as you can see here, when you use bendolizumab, it binds to the IL-5 receptor, and then once it binds to the IL-5 receptor on the eosinophils, it attracts the natural killer cells, and this natural killer cell will come to the eosinophil and cause apoptosis of the eosinophils. So it was seen that there is a near complete resolution of the eosinophils on exposure to bendolizumab in nearly 24 hours. And again, there is wealth of evidence, especially on bendolizumab, also different studies which have shown that it has got a good effect on severe exacerbations, improvement in the lung functions and the quality of life scores. And these are all the studies which have shown the oral corticosteroid sparing dosage. All this we can, whoever is interested can go through all these studies. And these are the recommendations from different professional societies, European, United States, Canada, and Australia, where they all this omalizumab, mepolizumab, and reslizumab and bendolizumab have been included in their armamentarium. I have not touched upon tupilumab. Again, it's not approved in India, and it's an IL-4 and IL-13 receptor blocker. This tupilumab. So this is one of the recent studies which was published in New England Journal of Medicine in 2021. Tezepelumab. So it's basically the importance of this is that it's an anti-TSLP is an upstream molecule. So it comes very high above the Th2 eosinophils and the IgE, the pathway, if you have seen that. So irrespective of the eosinophil count, if you use this tezepelumab, it leads to asthma control and reduces the asthma exacerbations. And is also very safe as per the study which was published. And the last but not the least, the non-pharmacological treatment for patients with severe asthma. Most of you have heard about this procedure, which is a therapeutic procedure for patients with refractory asthma. It's done by using a flexible bronchoscope. We know that there is a catheter which is passed through the flexible bronchoscope and which helps in applying the thermal energy in a systematic manner to the airways, which are 3 to 10 mm in diameter. And when you heat these airways, it's postulated that the airway smooth muscle decreases, the airway has hyperresponsiveness, the smooth muscle contractility all decreases. And again, it was also seen that the impact of asthma is not only on the smooth muscle, it was also found that it also alters the way inflammation affects the patients with bronchial asthma. And then this was one recent study, which was a small proof of concept study from European Respiratory Society, again, which said that when you use bronchial thermoplasty, it not only changes the airway smooth muscle, it also alters the way how inflammatory genes are expressed. Actually, this was a study of the transcriptomics on how the gene expression is happening on the airway epithelial cells. So to conclude my talk, look for all the 5 steps when you are dealing with the severe asthma patients, and phenotype these patients. And once you phenotype these patients, then you understand whether a patient is having an atopic asthma where IgE is elevated, where you need to use an omalizumab, or if you find that this patient is having an eosinophilic kind of asthma, then you use anti-IL-5 therapies. Again, there are patients where there will be atopic kind of Th2 type and eosinophilic kind of Th2 type of asthma, where you use omalizumab or anti-IL-5 therapy. Both of them are approved. And if you have a patient with T2 kind of asthma, you can either use bronchial thermoplasty, macrolides, or weight loss. The knowledge on asthma is ever evolving. I like this statement from clinics in chest medicine. So just when it seems that we know all there to know is about asthma inflammation, a major paradigm shift occurs that teaches us that we still have a lot to learn regarding the asthma. So in the last 2 decades, we have learned that Th17 cells play a very important role in patients with non-neutrophilic, non-Th2 type of asthma. Basically, they recruit the neutrophils and then cause neutrophilic inflammation. And again, a decade later, in this decade, 2010 to 20, we have learned the role of this ILC2, basically the innate lymphoid cells which play an important role in the asthma. So the field of asthma is ever evolving, and there is a lot to learn for us, especially with in the times to come. And new molecules are definitely going to come and help our patients, especially after treating them appropriately. Thank you all for the patient listening. I would be happy to take any questions.
Aspirin and asthma, is there a relationship, allergic airway disease, asthma and aspirin? So we use aspirin, and that's our holy grail, you can say.
Sir, there is a subset of patients which are called as aspirin-induced asthma, where the leukotriene mechanism plays a very role. In all the patients with asthma, there is no need to withhold or stop ecosprin. There is clinically, if a patient fits into that kind of aspirin-induced asthma, where the symptoms are getting aggravated whenever you're using aspirin, then those are the subset of patients in which probably you can withhold. It's only a small subset of asthma patients, I would say. And these patients actually, the Montelukast and all this anti-leukotriene will play a role. Montelukast, aspirin-induced asthma.
Vishnu, just one question. So just before I forget all my pulmonary medicine, because 3 years I think. So exercise-induced asthma for students and all, any elaborations? When exactly it happens? During exercise or after exercise?
Yeah.
Many students don't know this.
So most patients is basically the exercise-induced asthma occurs once the exercise is completed actually. When they come to the recovery phase, that is the time when the symptoms start. There is a small subset in which the symptoms start during the exercise itself. And there has been an important change in the treatment also of this exercise-induced asthma. Earlier they were recommending use of SABA before any exercise. But the recent GINA guidelines recommend use of ICS and the long-acting beta-agonist, the formoterol-glucinate combination for the exercise-induced asthma also actually, we have to use.
Just to add to what Dr. Shashi has mentioned, the whole thing started when it was called as King's Triad. It was asthma, aspirin and polyps. It's supposed to be around 9 to 10% of all asthma patients. So, but then we never had to stop aspirin for any patient for our asthmatics. So, and it's such a mild dose because it is about prophylactic 75 milligrams. And of course, abroad, I'm sure Dr. Pavan would say aspirin has very funny doses. I don't know how they arrived at those doses, but at least in India, it is very easy to remember 75, 150, 325, etc.
So invite Dr. Paranjot sir, Professor HOD, Respiratory Diseases, the Domestic Surgeon Dr. Subramaniam sir to join for this occasion.
కొంచెం దగ్గర వచ్చి పెట్టండి.
Is from the city and the whole south zone here. And especially you all postgraduates, I think some of you may be appearing for examination, and even after examination though, like learning goes on. You can see from Dr. Vijay Kumar, like I think he's close to 70 now, I'll not say the exact age, but still keeps on learning though, so that's spirit though. the outset, like I myself, I'm a pulmonary critical care doctor. I was in Michigan State, Lansing, and then my mind is in New York. After that, since 3 years, I'm mostly here in my other hat as administrative role. So almost forgetting medicine now. So, but then in my other role, though, I'm saying that you're in the right field, though. So people are saying I'm favoring the pulmonary department and all, but that's only because of the financial reasons. So that's one of the. So no department grew more than 1,000% in 1 year. Do you agree, Sai? Yes. So naturally, yes, the department is a favorite. But for all of you here, so you're in the right field, though. But that's only half the story. So the rest of the thing will be like if you want to be like here in the leading luminaries here, like in the first or second rows and all. So you need to differentiate yourself to first attending conferences like this. That's a great advantage, though. You need to see what are the experience of all these people here. Now it may seem simple and all, but it starts with basic work. First of all, the subject knowing and all, and secondly, nowadays, because there's so many doctors graduating nowadays from India, so we need to differentiate. Always there is a role for people who differentiate themselves. So starting with publications and all. Many people, almost everybody will need some kind of publications going forward. I'm thinking 10 years down the line now. And it's not that tough, though. Sometimes it may feel like, these big journals and all, will they accept mine? What should I do and all that? Sometimes it's just a matter of selecting interesting topics. I remember my first case presentation for a chest journal or something. So I think mainly because of the topic it got selected, I think. In parenthesis, I am Superman - psychiatric manifestations as an initial presentation of lung cancer. That patient was behaving like US and New York. I guess daily Superman, where are you flying? We used to ask him daily, used to say something, but just based on name also, I think they are not super complicated people there. So please don't restrict yourself. Even international journals also, you should aim to publish the case reports. One day, probably I did 5 or 6. That's not that tough. And studies too. Any studies, any kind of things. COVID is there, not COVID. I think what was that? I did 500 patients. Yes, CTPA too. CT just to rule out pulmonary emulsion. We used to write it left and right in US and all, but there the incidence was only 2%. So that was also how effective are we or something like that. I put it. But publications is one thing. Knowledge, being up to date with the procedures, knowing all the relevant people, and nowadays it's become very important to be on social media and all. Personal things I don't recommend. I'm not commenting, but otherwise, so all of these process and all you can follow, and you should also have all this Facebook, Instagram, YouTube channels and all. Everything is required. The majority of the information you can gain from there, and people will know about you too. So I don't want to take too much of your time, but this entire 2-day session, you'll have a real all-star crew here. Please make use of them and aim for bigger things. You'll do good. Thank you.
I request Dr. Gopi Krishna, Senior International Pulmonologist, to present sheet to Pawan sir.
First point, I love postgraduate students. They say the best time to plant a tree is 20 years ago. But the second best time to plant a tree is today. So if you have missed planting a tree 20 years ago, you can plant it today. So whatever you didn't do all these years, you can start doing it from today. And you may have a feeling that by enrolling yourself in the postgraduate course, whether it is DNB or MD, that you will learn everything from the teachers and then go back perfect into the market. That is not going to happen. Because there is a beautiful Sanskrit saying which says 25% comes from the teachers. Only 25%. 25% comes from books. And 25% is taught by the patients. So there is 75%. And the last 25% comes from your own observations. As you keep seeing patients, as you keep observing, oh, these two people came with the same problem, I gave the same medicine. This guy died and this guy survived. What happened? So you will have to ask yourself and learn. So for every mistake that is committed, you will have to introspect and then find out the solution. Only then you will get better. And the last thing that I would say, after you step out of this hospital with your MD or DNB, you want to be a good doctor, earn a lot of money, buy a big car. So how do you increase your practice? There is a secret. How do you increase your practice? The secret is very simple. Take care of the patient who is sitting in front of you. Make him 100% satisfied. When he goes out, he should say, what a wonderful doctor I met. And he is going to be your marketing agent. And you don't have to pay any money to him. Free. He is your marketing agent. So create about 1,000 marketing agents, all of them without salary. They go across to different parts and talk about you. What more you want? So you have hit the golden point. Thank you very much.
Coming and attending this session. And I also express my sincere thanks to all the senior faculty who have come and graced the occasion. Now that comes to the end of this inaugural session. Now we move on to the further tasks.
Coming to next talk, we have a talk on bronchiectasis. I request Ms. Hyderabad to present the talk. Thank you.
Good morning, everybody. My teachers, friends, colleagues, students. It's a pleasure to be here in flesh and blood, breathing the same air for a long time. In the next few minutes, I'll be talking to you on bronchiectasis. The topic that is given to me is bronchiectasis, the orphan disease, and evolving concepts. Is bronchiectasis really an orphan disease in 2021? We know that bronchiectasis is globally prevalent and the incidence is increasing globally because of the various reasons, either because of aging population or because of the availability of HRCTs or the physician's awareness to diagnose bronchiectasis is more, or many comorbid conditions are there existing with bronchiectasis. So it is going to be a problem that we will be facing day in and day out, even 20 years from now also. And the prevalence, as it is depicted in the slide, it is seen both in developed countries as well as in developing countries. Rich countries, poor countries across bronchiectasis is seen commonly. And in fact, it is one of the third most common cause of chronic inflammatory airways disease next to asthma and COPD. And the global economic burden is very huge. That's why the pharma industries have put in a lot of money. And there you see in 2008, there were only 91 RCTs that were published, and by 2019, they went up to 252 RCTs, and the RCTs are increasing day by day because of thanks to the pharma industry. And the first national guideline in the management of bronchiectasis was published way back in 2002, but that was mainly in the management of bronchiectasis in the native children of Australia, and followed by many national guidelines have come out, and as late as 2017, the European Society has published its first guidelines in the management of adult bronchiectasis. So there we are very soon, or it's already no more an orphan disease. So thanks to EMBARK and EMBARK India, we have a lot of data on bronchiectasis coming up. There you see the bronchiectasis patients as compared to the American or US or European countries. Our patients are much younger, usually more males, and non-smokers are more in bronchiectasis patients. And a lot of them have a lot of comorbidities, and the comorbidities that are commonly associated are asthma, COPD, HIV, and all these things. So thanks to EMBARK that we have a lot of literature coming from India as well, and that's getting published. Looking at the etiology of bronchiectasis across various countries in the world, the infectious causes and idiopathic causes of bronchiectasis are reported more from the developing countries as compared to developed countries. And if you look at the bronchiectasis etiology in adults, you will see that the infectious causes or the idiopathic ones are becoming less and less, and more of aspiration-related or COPD, asthma, connective tissue, things like that are more and more in developed countries. And even in India, once we control the infections, there are other reasons for patients to develop bronchiectasis. Now going to the pathogenesis of bronchiectasis, way back in 1986, it was B.J. Cole who gave us this vicious cycle hypothesis of bronchiectasis. Once there is an inflammation, and once this inflammation is amplified and it becomes a chronic inflammation, this chronic inflammation causes tissue damage, causing bronchiectasis, and then microbes set up their refractory there and then cause inflammation, and this cycle goes on and on. That's how bronchiectasis is produced. Now, from 1986, now in 2018, Flum gave us another hypothesis. From vicious cycle, we have come to vicious vortex, wherein multiple domains interact with each other in a very complex way. Not just one event causing another event, another. Unlike the Cole's hypothesis, the Flum's hypothesis is vicious vortex where each domain interacts with in multiple ways, and then there is this damage to the airways causing bronchiectasis. Central to the pathogenesis of bronchiectasis is the inflammatory cell called neutrophil. But then the neutrophils in bronchiectasis patients are a little different. These neutrophils are reprogrammed, metabolically reprogrammed neutrophils. So they survive long with an impaired antibacterial activity. Neutrophils also form enetioses or neutrophil extracellular traps. See, NET traps or the enetioses itself is an inflammatory thing, and along with NETs, pregnancy zone protein is released. This pregnancy zone protein is released from the neutrophils of a bronchiectasis patients, which is an immunosuppressant. So because of the pregnancy zone protein, the neutrophils are not able to eliminate the microbes. Neutrophil elastase is the key driver for pathogenesis of bronchiectasis. It drives mucus hypersecretion, and high neutrophil elastase in sputum results in Pseudomonas aeruginosa infection, low microbial diversity, and predicts the exacerbation survival. Next we go to the mucus. The mucus in the bronchiectasis patients exhibits an increased percentage of solids in the sputum. and total and individual MUC5B and MUC5AC mucins are elevated, and this will result in increased osmotic pressure of the mucus, and there is an increased elastic and viscous properties of the mucus, impairing the mucociliary action of the cilia of epithelium. There you can see MUC5B and MUC5AC are elevated, and this could be a marker of treatment response that we will see later. So once there is an insult to the airway epithelium followed by dehydration or poor hydration, this mucus, this will cause mucus, yeah. So this insult will cause increased mucus secretion, and when this mucus goes and sits into the airways, this further causes activation of the macrophages, airway macrophages, and the hypoxic environment, chronic infection, and airway obstruction, all of them together cause further increased mucin production, and there will be a parallel neutrophil inflammatory reaction that will start. So all these things put together, increased mucus, viscous mucus will impair the mucociliary action, and then the stasis of the mucus, obstruction, and then inflammation, further inflammation. So, and then there you have the bronchiectasis developing. So, how do we treat this mucus hypersecretion? We know that there are hypotonic saline and mannitol clinical trials in bronchiectasis, but they are not 100% effective. But there could be a group of patients who will respond to hypotonic saline. And what is the marker for this? So if we have increased mucin percent solids in the mucus, if we can identify, there you can see in this study, there was a 25% reduction in mucin with hypotonic saline if hypotonic saline is given to bronchiectasis patients who have more solids in their sputum. Now coming to aging and bronchiectasis, in elderly there is increased prevalence of bronchiectasis, and particularly severe disease. They have atypical presentations and poor outcomes compared to younger patients. This is because of the microaspiration of the nasopharyngeal secretions or because of the immunosenescence. Immunosenescence is the impaired immune system activity in the elderly people. The immune system responds poorly to new antigens. There is a lot of accumulation of memory cells, and these memory cells will further cause inflammation and tissue destruction and bronchiectasis. And there are other inflammatory pathways that get activated in older people. So, longer the people live, greater the chances that they are going to have bronchiectasis for various reasons, not necessarily infections. Now, once we have talked about neutrophils and mucus, and we come into the mucociliary action. Primary ciliary dyskinesis is, though less common, it is still reported in adult bronchiectasis patients. So, in days to come, maybe we are going to see bronchiectasis due to primary ciliary dyskinesis even in adults. But how do we pick up these patients? The diagnosis is very difficult. Whether there are three parameters that can help us in making a diagnosis of obesity in adults. First is nasal nitric oxide. Nasal nitric oxide, if it is low, and if we have ruled out cystic fibrosis, then it's almost a diagnostic. It's not diagnostic, but then the specificity of obesity is high. The second is finding out the genes that can cause obesity. There are about 36 genes that are described. So if you, with the NGS platform, you can pick up a lot of genes. So if you pick up these genes, then we're likely to have a diagnosis of obesity. The other is microscopic diagnosis, electron microscopic diagnosis. So if you have electron microscopic diagnosis of the ciliary dysfunction or the structural deformities, you have made a diagnosis of obesity. So putting all these together, genes and electron microscope and then nasal nitric oxide, all these will help in making diagnosis of primary ciliary dyskinesis even in adults without a dextrocardia or cytosinosis. The word about idiopathic bronchiectasis and NTMs. This is again a special phenotype where the bronchiectasis patients with NTM have different endotypes. So it could be a ciliary variant, it could be an immune variant, it could be a connective tissue variant or a cystic fibrosis variant. So once you have an idiopathic bronchiectasis, then we will be looking for these variants. So, and each of these endotype, there are some drugs that are being tried. So in days to come, maybe we are going to treat these patients in a very personal way, that is called precision medicine. So idiopathic bronchiectasis, there is a lot of things that are happening in this field also. Coming to the pulmonary function test, this is a pilot study of 187 patients from EMBARK, European countries. They have a mix of patients were included in the study. What is important is, if you just do spirometry, only 9.7% of them will have abnormal spirometry. So if only you stick to just PFT spirometry, you will lose a lot of abnormalities that are happening in the lung function. So the major findings of that study was close to 60% of patients, plethysmographic and BLCO assessment detected lung function abnormalities that would have been missed with the sole spirometry. So we should be using more and more of other lung functions, not just spirometry. And air trapping and BLCO impairment are the most common lung function abnormalities. It's not just obstruction, but air trapping is much more common. And now we know that small airways obstruction is a major part of bronchiectasis also. And then there is this reversibility in residual wall. Now we'll go to microbes. And so this is this was recently presented at the European Respiratory Society International Congress, where they have shown that the Pseudomonas and H. influenza, Enterobacteriaceae, these are the common microbacteria that are found in patients, sputum of patient with bronchiectasis. But what is interesting is they persist. Once they set up their factory in the bronchiectatic airways, they persist. So there is no role of eradication program as such, because it's just sputum conversion, positive or negative. If you isolate Pseudomonas today, 3 months later, they will disappear, and then 3 months later they will reappear again. And then if you just do a conventional culture, you are likely to miss all these organisms, even if the sputum by conventional culture is negative. If you use molecular diagnosis, you are going to pick up all these things. This is called the microbiomata. So the microbiomata in the bronchiectatic airways are going to stay for a long time. And the risk of mortality again is high with fungus. I mean, this is something new. This is from the European study just recently presented. We don't have such data from India, but maybe we have to look into the fungus also in our chronic bronchiectasis patients with a recurrent exacerbations, because they have got very high mortality rate. Yeah, this is from EMBARK India, the data that's published, the microbes, only the bacteria are published, and I mean the Pseudomonas and Enterobacteriaceae, the Klebsiella variety, these are the common across whatever in the etiology of bronchiectasis. And again, in ERS, Dr. Rajendra has presented a 4.5 years follow-up of this EMBARK India study, and again they have said that the same bacteria, they persist also. So once you have bacteria developing in the airways, they persist for long. So it's not just bacteria, virus and fungus are also part of this microbiome of bronchiectatic airways. And it is found, it is mentioned that these microbiome, whether bacteria, fungus or virus, they are different whether in developed countries versus Australasia. So it is different in India. The microbiota is different in India as compared to microbiota in Europe or America, but we don't have any data from India. This is predominantly from Australasia. So the microbiota of the airways, especially bronchiectatic airways, is so heterogeneous, and heterogeneity is a good marker actually. If there is a loss of heterogeneity, that means there is something wrong in the airways, and these are the patients who are likely to have exacerbations. So loss of heterogeneity is bad for bronchiectatic patients. So this is bacteriophage composition in bronchiectasis. Again, we're using molecular diagnostics. The viral clusters, bacteriophage clusters are different whether in Asia or Europe. And the importance of finding out these bacteriophage clusters is because they contain these resistomes. Resistomes are the genetic material that confer resistance to antibiotics. They pass on the resistant genes to bacteria. The virus, they pass on the genes to the bacteria for the drug resistance. So having a cluster identification of bacteriophages will help us to choose which is the most appropriate antibiotic in a given patient at a given point in time, and that will help in antimicrobial stewardship. So the conclusion of this microbe and microbiomics is the infection is associated with clinical features. Say, for example, younger age patients, they have more of Staphylococcus aureus, H. influenza, Streptococcus pneumoniae. Bronchiectasis with chronic rhinosinusitis, H. influenza fungus, and Staphylococcus aureus. And patients with gastroesophageal reflux disorder have a lot of Enterobacteriaceae and Serratia massicans. So apart from the known adverse outcomes with Pseudomonas aeruginosa, what is coming out is it is the fungus and Enterobacteriaceae are also associated with increased mortality and low quality of life in patients with bronchiectasis. Now coming to the eosinophilic inflammatory phenotype. Now across various countries, about 5 countries in Europe, what they have found is among bronchiectatic patients, 22.6% of them have eosinophilic inflammation. That is, eosinophil counts of more than 300 in their blood. And patients who have predominant eosinophils also have different microbiota. So higher eosinophil counts have higher Streptococcus and Pseudomonas. Low eosinophil counts have eosinophils. So this is something new information. And patients who have eosinophilic inflammation have increased exacerbation rate, and the time to exacerbation is also reduced in those patients who have eosinophil counts of more than 300. So now, who are the patients who are going to respond to inhaled antibiotics in reducing exacerbations of bronchiectasis? So patients who have high bacterial load, if they are given inhaled antibiotics, they are the ones who are going to respond better. But how do we know that the patient has high bacterial load? No. This is by a surrogate marker or a biomarker that is there, that is sputum neutrophil elastase. So if you find out neutrophil elastase levels in the sputum, then that is surrogate marker for response to inhaled antibiotics. So this is again from the study that shows that high bacterial load and high neutrophil elastase are the group of patients who respond to inhaled antibiotics, not all of them. So this is a bedside test that is being developed in the University of Dundee by James D. Chalmers, where sputum neutrophil elastase levels can be estimated. So it would be a point of care test. And then if it is available, it will be very useful in days to come, so that if you have a high neutrophil elastase sputum, these are the patients who are likely to respond to inhaled antibiotics. Then who are the group of patients who will respond to inhaled corticosteroids? Now, there is a study published in ERJ 2020, and post hoc analysis of this trial showed that in those patients who have more than 3% of eosinophils in their blood, there is a 47.4% reduction in improvement in their quality of life as those patients who have normal eosinophil. Or if the eosinophil counts are less than 150, inhaled corticosteroids are not going to be helpful. So patients who have bronchiectasis, recurrent exacerbations with elevated eosinophils more than 3% or more than 150, these are the group of patients who are going to be benefited with inhaled corticosteroids. Again, a group of 21 patients were studied using monoclonal antibodies. So patients bronchiectasis with recurrent exacerbations with T2 high phenotype, when monoclonal antibody like antifile was given, there was improvement in lung functions, exacerbation rate reduction, dyspnea, and improvement in quality of life. Now we are going back to the vicious vortex to understand how an exacerbation of bronchiectasis happens. For us, bronchiectasis exacerbation is always bacterial infection, but it is not so. As you can see here, it's not just infection, inflammation, severe dysfunction, structural damage, but each domain itself can cause an exacerbation. Say for example, if there is a structural damage itself interacts with all these things that cause exacerbation of bronchiectasis. Simple mucociliary dysfunction on its own will cause exacerbation of bronchiectasis. So exacerbation of bronchiectasis is not just bacterial infection, but it is multifactorial. That's what we have to understand. So the ERS guidelines for adult bronchiectasis management when it comes to prevention of exacerbation in the algorithm, macrolides are given only in those patients who have non-pseudomonas infections. But according to this algorithm by Laska published in 2019 in ERJ, he says that macrolides have to be given very early on. Long-term macrolides have to be given very early on, and only if macrolides fail, then you go on to the treatable traits strategy. And the treatable trait strategy would be if the macrolides fail, if the patients have increased bacterial load, that is increased neutrophil elastase in sputum, you inhale antibiotics. If the patients have mucus plugging, that is, if there is more solids in the sputum, MUC5B, MUC5AC mutations are more, then you can give him hypertonic saline. If there is eosinophilic inflammation, give steroids or monoclonal antibodies. So that's the new algorithm that is being proposed now. The new molecule that is coming up, brensocatib, is an oral drug. It's a 90 neutrophil elastase, given once a day, 100 milligrams, and in clinical trials, there is a 42% reduction in exacerbation rate, and US FDA has given, it has breakthrough therapy designation to this molecule, so maybe it will hit the market very soon. So we know that in the management of bronchiectasis, we have these treatable traits, but what is exciting for the future is targeting the targetable traits. So if you have a patient who has dysbiosis, either bacterial dysbiosis or fungal dysbiosis, how do you treat this? If the patient has neutrophilic dysfunction, as you said, the neutrophils of bronchiectasis patients are reprogrammed, they are not normal. So how do we treat this neutrophil dysfunction, make them functional again? So there are some good clinical trials that are exciting trials. So all these, the new things, the targetable traits are the ones which are for future in days to come. So to conclude, bronchiectasis is a very heterogeneous, there are many endophenotypes. From vicious cycle, we have moved on to vicious vortex in understanding the pathogenesis of bronchiectasis and also to explain the exacerbations of bronchiectasis. All these omics are helping us in giving us point-of-care tests in the management of bronchiectasis and giving personalized therapy, and targetable traits are for the future, very exciting. And artificial intelligence is already there in cystic fibrosis, and it will spill over to non-cystic fibrous bronchiectasis. And aspiration goals are one day we are going to reverse the damage and cure bronchiectasis. So thank you for your patient listening. So if there are any questions, I will be. Coming to the dose of macrolides, yeah, it's either 500 3 times a week or 253 times a week. But the understanding for bronchiectasis is 250 is a good immunomodulator and 500 has got more side effects. So I think 250 should be okay for long-term use of macrolides in this group of patients. So yeah, and then macrolides is a poor man's biologic. So it has to be tried much early, even in asthma patients. Just like in bronchiectasis also, it has to be tried much earlier. It is a poor man's biologic. Very good immunomodulator. I think 250 milligrams per day for 3 days in a week should be okay. Either daily or alternate day. And before we give macrolides, make sure that we have ruled out atypical mycobacterial infections. So make sure that you are not dealing with atypical mycobacterial infections, especially if you have a very lower lingular bronchiectasis where atypical mycobacterial is a possibility. So having ruled out atypical mycobacterial infections, give macrolides. That's very important. And as a briquellatic, I think $300 is what that is recommended for cystic fibrosis. It is not to be given in non-cystic fibrosis bronchiectasis patients.
Thank you, sir. I request Ramakrishna sir to present sheet of Pharmacogenomics.
Good morning, everyone. This is the place where you are sitting right now, at Yashoda Hospitals, Secunderabad, and I work here as interventional pulmonologist. You might be tired, COVID, and again COVID over here. So most of you guys might be working in COVID ICUs or in COVID wards. I hope so. It's right? So I'm not gonna, talk a lot about the studies or trial drugs and all. We are going to focus only on the guidelines, like Dr. R. Vijay Kumar sir had said. Anything evidence-based should be, treated or given to the patient. So that is good for the patient and good for you too. So because already we are seeing some cases, firing at us why this drug was not given, why this drug is being given, why the result was good, why the result was bad. So I feel we should stick to the guideline and treat accordingly. So what are the challenges we face during the acute COVID? This is what we are going to cover it in next 6-7 minutes. And acute COVID is predominantly about the severe disease which we will be going through. We all know how the COVID presents into the ER and what are the challenges in the diagnosis, what are the challenges in the management, and what are the complications which we have seen, the immediate complications. So we all know, COVID presents in wide variety of symptomatologies and all. Here in this slide, we can see COVID can present, with asymptomatic sometimes to simple cough, fever, and coryza, and to breathlessness, life-threatening breathlessness, and probably patients needing oxygen or ventilations and hospitalization, ICU care. These are the wide varieties of presentations what we see in COVID. So in this slide, I would like to particularly point that the problem starts after the 7th day, where we can see that most of the patients develop some amount of breathlessness or symptoms, and from the 10th day, we can see at least 15-16% people are having trouble landing up into the hospitals and ICUs. So, like I said, these are the 3 points which we are going to touch about diagnosis and treatment. Treatment would be medical and ICU and organ support, as well as the complications. So in the diagnostics, there are 4 things which we have decided, like antigen testing, which is the hot favorite, across the Twin States or any part of India right now, and the molecular testing, the gold standard, and the serological testing, plus minus, lots of questions about serological testing and radiological confirmations. So what are the problems we face and what we should do, how should we interpret these testings should be our target in the future course of treatment of these COVID patients, because we are going to face legal issues also in coming days. So this is all about the IDSA guidelines which we are going through, like whether the rapid antigen test or lateral flow assay we say in a fancy way. Okay, this one, we gives the report within 15 minutes probably in the point of care to diagnose the patient whether he has a COVID or not. But whom all should we test? We can see that symptomatic individual should be run with an RT-PCR or nucleic acid amplification test would be an ideal one when compared to rapid antigen. You don't have an option, then you can go with the rapid antigen testing. And whether the patient is is asymptomatic but he has an exposure to the COVID positive patient, probably might help us in diagnosing the patient. and especially in asymptomatic patients who are not exposed, or they don't have much exposure to the COVID positive patients, a simple rapid antigen negative would be sufficient for us. So molecular testing regarding the RT-PCR, we can see that it is recommended by the IDSA that whenever there is a community testing, community spread, we have to do an RT-PCR, not a rapid test. Okay. Second, they have suggested a combined nasal as well as an oral swab, rather than a single swab like an oral swab, or only a nasal swab will not be sufficient enough. And they suggested any patient who presents with respiratory like flu-like illness and upper respiratory sample would be sufficient rather than lower respiratory tract sample, unless and until twice we have done the RT-PCR and still it is negative. We have a strong suspicion, probably we can get the sputum or endobronchial secretions to test for RT-PCR. And single RT-PCR would be sufficient when there is a low clinical suspicion. And regarding the asymptomatic patients, exposed, suspected patients and immunocompromised patients who need admission, all these patients should be tested before we go for admission, especially the immunocompromised ones, and as well as patients who are planned for transplants should be tested with an RT-PCR before we go for an admission or any procedure. But they didn't give any recommendation regarding patients if they have to go for immunosuppressive therapy regarding cancer or autoimmune diseases. They said there is no particular recommendation till now as per the studies. So when there is low prevalence, no test is required, but when there is high prevalence, or whenever we plan a major surgery like a CABG or any surgery, thoracic surgeries, it is better we do an RT-PCR. The thing is, we all come to the point, do we need an RT-PCR while we do a bronchoscopy? So the IDSA has suggested, they use fancy, terminology, time-sensitive aerosol generating procedure. What are these? Time-sensitive. One of the thing is bronchoscopy. There are n number of things. Here you can see. So simple bronchoscopy, sputum induction, nebulizations, your NIV, CPR, all these things are aerosol generating procedures. So whenever we do an aerosol generating procedures, if you have a PPE kit and the patient doesn't have an exposure to a COVID patient, you don't need an RT-PCR. But you don't have PPE kits, or there is a compromise, then better you get an RT-PCR for the patient and subject him for bronchoscopy. This is what the guidelines are. And regarding the serological testing, we use these antibodies, IgM, IgG, left, right and center in initial days to identify the disease. Yes, pre-vaccination, post-vaccination era in COVID will vary these results. So strictly the guidelines suggest we cannot use the antibody assays to diagnose the disease, except in very, very few conditions, like in a pediatric diseased patients, especially when they are having multiple inflammatory syndromes, then they can use IgG as well as with the NAT to help in identifying the disease, whether they had COVID or not. But you cannot use it to diagnose, you cannot term a patient as COVID positive just on the basis of antibodies. So this is gonna bounce at us if you start treating them with antibodies. So regarding the radiological appearances, here we have RSNA in consensus with the Society of Thoracic Radiology and American Society of Radiology. 4 appearances they have described. The first one would be the typical appearance. Typical appearance is when you have bilateral GGOs with plus or minus consolidations, whether they are peripheral or not, with a typical crazy paving. Particularly, I want to state my personal experience. Whenever we see these crazy paving appearances, they have fared very bad. So the first bad prognostic sign what I have seen was having crazy paving in the CT scan. Those patients took a long time in recovering. Those patients required oxygen. Those patients required ICUs, and we lost some of these patients also. A reverse halo sign might be, with organizing pneumonia. Identification is one of the typical appearance. And indeterminate appearance is the same findings, but they are not peripheral, or they are not rounded, or they are not, bilateral. In those conditions, we call it as indeterminate appearance. This is important. Probably, one of the exam questions in whole of COVID would be, the CT appearance or the drugs The third thing would be the instruments, or the what you call the HFNC or the ECMO. These might be some of the questions you might, encounter in lieu of COVID in the exam. So atypical appearances are also there, isolated single consolidation on one side, probably with interlobular septal thickening. So there we get, the RT-PCR turning to be positive, giving us, the COVID diagnosis. So there are atypical appearances. And the last one is when there is no evidence of any, CT change or a parenchymal change, then it is called, no evidence of any pneumonia. Right? This is a, we can see in every CT scan, right? The CORADS classification. It is from the Dutch Association of Radiology. So CORAD 1, 2, 3, 4, 5, and 6. 6 is nothing but PCR positive. So we don't have, go about with the CORAD scoring. It doesn't help us in any way, being the clinicians and all, whether the rapid test is positive or RT-PCR is positive or the CT is having a COVID change or not. This is what happened in both the waves. So the CORAD scoring might be useful for the patients. They start bugging us, what is the score? Isn't it? The CORAD scoring initially, and now they ask out of 25 and out of 40, what is the scoring? Did it reduce after treatment? They expect it to be 0, right? When we start talking about the score, you should tell them that the score is not going to change. Because if the score is high, it's going to get fibrosis, the score might be same. So that's the reason whenever, the CT scan is repeated in the same hospital, in the second scan, they don't give the score. They tell you about whether there is an improvement or not, whether there is any complication or not, or whether there is any fibrosis or not. So coming to the medical management. So in the medical management, you all might be knowing a lot of things, how we treat. Yeah, we have a protocol. Whenever a patient comes to ER, there is a protocol. Gopi Krishna sir's protocol, Gangadhar sir's protocol. There are different protocols, but the common drugs are same, right? COVID positive, start remdesivir, right? Isn't it? You agree or not? Right? Remdesivir, steroid, blood thinner. So let's see what the guideline says. Okay? So in the first thing I want to talk, whoever, patient walks into the OPD, what we prescribe? Azithromycin, doxycycline. Isn't it? Sometimes patients might be taking azithromycin, doxycycline for 14 days by their own, or, everyone who with an MBBS degree has become a COVID specialist. I don't want to comment in a negative sense, but I've seen everyone from, MBBS to whatever level they have. So there were n different, treatments which have been put on the patients, and they have bared it. So the guideline suggests regarding the post-exposure prophylaxis or the treatment aspects, there is no role of azithromycin or your doxycycline at all. Absolutely no. And it has been, the chloroquine too, the drug favored by India, right? Particularly in India, still most of the guidelines and most of the practitioners still use chloroquine. So the guideline says there is no role of chloroquine. Yeah, why do we choose those? Yeah, they have some implications. Like Dr. Paramjyoti sir said, Dr. R. Vijay Kumar sir said, yes, azithromycin has some properties like anti-inflammatory properties, and it has some antiviral properties too. Okay. Similarly, chloroquine also has. Probably it might help was the thought. But now, because we know the guideline doesn't suggest to use azithromycin as well as this chloroquine, better we stop. Okay. And there is no role of this, the drugs which we use in HIV, the lopinavir and entecavir, absolutely, that we came to know before we entered the first wave, right? So don't use those drugs too. Second, regarding ivermectin, how many of you still use ivermectin? No? Even now the prescriptions go out with ivermectin, right? So there is no role of ivermectin at all. Neither in the patients who are in mild, moderate or any severe category they are. Famotidine. This was also one of the drugs which circulated across, famotidine has a little better advantage than, pantoprazole or our ranitidine. So they suggest no. Regarding the convalescent plasma. So you guys might have given plasma therapies, right? So the articles and the guidelines are against plasma. So there is no role. Yeah, we used plasma as a passive immunotherapy. Yeah, we thought like the antibodies will help fight against the disease or neutralize the inflammatory cascade which is happening with COVID. So, but we have seen that the studies are showing there is no absolute benefit neither in the symptomatology nor in the mortality when we use plasma. So they have said there is no role of plasma at all in the therapy of COVID. Unfortunately, some of the consultants are still using plasma. Patients are running, pillar to post to get the particular donor to get the plasma for his kith or kin who is lying in the ICU bed or on ventilation. Yeah, plasma, the guideline says to be used as a clinical trial. You want to do some research for the mild to moderate disease, you can try convalescent plasma, not in severe disease. And regarding remdesivir, every patient got admitted would be receiving remdesivir, right? You don't give remdesivir, the patients are angry. The attendants are angry. If there is a shortage or not. You say, no, for you the remdesivir is not required, you have a mild disease. Will they accept? No. That's all because of the media hype. They initially said this is the life-saving drug. But of late, the trial, the WHO Solidarity trial, I think you guys need to learn about some trials of COVID too, especially the recovery trial and the Solidarity trial, which are very, very important, which will tell us how we should go about in the treatment of COVID. So regarding this remdesivir, there is no role in mild to moderate. Only in severe condition they are advising. Patients on ventilator or patients requiring ECMO, there is no role of remdesivir. Who are about to get onto ventilation or requiring high oxygenation, or we say it as severe hypoxemia. So in that condition, remdesivir may be tried. So the role of remdesivir and role of the treatment of COVID when we compare with steroid and Clexane or your low molecular weight heparin is only 5 to 10%. So who will tell them? Who will tell the patients? Because we don't practice, right? So these are all the guidelines what they suggest. And next coming to the IL-6 inhibitors, the most expensive drug, right? Tocilizumab. Expensive in the way not in the MRP, in the black market. It rose to 2 lakhs, 3 lakhs. I heard a patient got it for 7 lakhs when there was a wave. Okay? So is there a role of tocilizumab? Yes, there is a role of tocilizumab, especially in the severe and critical patients. Okay, whenever they are in severe hypoxemia and when they are in hyperinflammatory state. So not only the IL-6 we have to check the CRP. The guideline suggests CRP if it is above 75, then probably the tocilizumab might help the patient. Okay, it reduces the the progression of the disease. It reduces the inflammation. It reduces the mortality of the patient for the next, in the 28-day mortality is less. So some of the patients might be requiring a second dose too. So the guideline didn't suggest bevacizumab, the guideline didn't suggest infliximab, the guideline didn't suggest methylamine. Vishwanath is not there. His favorite is methylamine. So there are some, cytokine inflammatory syndrome, or these are all cytokine blockers. So different blockers are there. So the guidelines suggest only tocilizumab. Along with this tocilizumab, for some patients we can't give steroids. So we use these Janus kinase inhibitors. These are the novel drugs which we got in the second wave, the end of second wave probably. We call it as baricitinib. You guys might have heard it, right? It's an oral drug. So they are usually Janus kinase inhibitors, the JAK1 and 2 blocker, specifically selective. So you need to know about this drug in detail, probably one of the exam questions. So this can be given along with remdesivir and a steroid. Isolated individual in a single drug of baricitinib is not advised. So these drugs can be used in severe disease, not in mild moderate, or neither in the critical phase. Similarly, baricitinib we have tofacitinib. That's also a JAK inhibitor, JAK 1 and 3 inhibitor. What these drugs do is they down-regulate the inflammatory mechanism, or they block the cytokines. Thereby, the inflammation cascade is put on hold, and the disease comes to a halt. So these also have come up in the Act 2 trial. So there are few trials we have to know about COVID. I don't want you guys to go through all the studies and all. At least Solidarity trial, Recovery trial, and ACT trials are very, very important. And coming to the monoclonal antibodies. You have been hearing monoclonal antibodies since the day started, isn't it? You heard it in asthma, you heard it in bronchiectasis. You will hear everywhere in pulmonology, from cancer to the acute disease to the chronic disease. So we have to know what monoclonal antibodies are being used in whole of pulmonology department, okay, with all the different pathologies which are there. So that might be a broad question for us. Monoclonal antibodies might be very easy for an examiner to give it, but to write it would be really difficult. So what monoclonal antibodies we will be using? Okay, why do we use them? So you can see in the picture, the SARS-CoV-2 virus. So there are spike proteins, and the spike proteins get lodged onto the host cell. Okay, so these monoclonal antibodies block those spike proteins so that they don't get attached to the host cell, and thereby reducing the inflammation would be coming down. The disease progression would be coming to a halt, and the viral load would be reduced. So what are these monoclonal antibodies? Where do we use? So these are the following conditions where we use it. You might be knowing the antibody cocktail, right? Now, which we are seeing in the last couple of months, right? Do they work? Yes, they do work. So are we using it as a therapy or a prophylaxis? There is a difference in it. We are using it as a prophylaxis, not as a therapy. So what all, who are all the eligible people? You can name any person with any comorbidity, he is fit for these antibodies. You can see that, older age, obesity, pregnancy, CKD, diabetes, immunocompromised state, anything. And anyone who is on gastrostomy, tracheostomy, not non-COVID ones. So what are the contraindications where we should not use this antibody cocktail or antibodies? So there are certain contraindications. People who are already hospitalized or on oxygenation for COVID-19. So in those conditions, we don't use these antibodies. And people who are on mechanical ventilation and giving antibodies might be detrimental, what the study says. So as a prophylaxis, we are using Casirivimab and Indevimab, 600 of each we will be using, and we will be giving it as an IV or a subcutaneous. So there is a second drug which is Bamlanivimab and Etesevimab. I don't think so it will get launched in India because US has bought out the Bamlanivimab for next 2 years or 3 years. So that is used as a therapy in mild to moderate disease. These things are showing significant change, and these are helping the patients in reducing their mortality and reducing their severity of the disease, landing upon to ventilation by almost 78%. So regarding the management of ARDS and refractory hypoxemia, what we face in COVID, there are small changes when we treat a routine ARDS with a bacteria or any other virus and with COVID. So management of ARDS is oxygen support along with mechanical ventilation in the treatment of underlying cause. Mild ARDS can be managed only with NIV or HFNC, mild to moderate, but in severe cases we need endotracheal intubation and mechanical ventilations too. So this is the point which I would like to stress. There is something called lung protective ventilation, especially in COVID. So the protective lung strategy is also known as open lung approach, okay, and is the standard of care in the management of ARDS with COVID. So it's a combination of low tidal volume ventilation and application of PEEP above lower inflection point. I will explain that. So lower tidal volume ventilation frequently results in alveolar hypoventilation, leading to permissive hypercapnia. LTTV also induces shear injury. So to reduce that shear injury, we use the PEEP. Okay, PEEP is just to expand or open up the alveoli. So high PEEP is not advised in COVID. Did you guys see pneumothorax? Did you guys see mediastinal emphysemas? Did you ever see pneumothorax and mediastinal emphysemas in other ARDS patients? But we have seen a lot of cases coming up, with COVID. So that shows that the lung becomes so stiff, even slightest of the pressure which we increase is going to result in barotrauma or volume. So far universally accepted method of applying PEEP was established, applying the highest PEEP, limiting the plateau pressure max of 28 to 30. The two plateau pressure 28 to 30 we use in obese patients and with lower respiratory compliance like any kyphoscoliosis and all. In those patients we try to give the highest plateau pressure, or else we usually keep it on the lower side. And it is a reasonable approach to ventilate them. Same thing, SCCM recommends setting of ventilator of tidal volume 8 ml per kg. Usually 6 to 8 would be fine, or little lower depending on the sex and the age and the weight. And plateau pressure max of 30, not more than that. And initial PEEP should be 10 to 12 is what SCCM suggests. My personal experience, any patient on 10 and 12 are landing up with mediastinal emphysemas. So in our hospital we practice at the max of 8 unless and until we have very bad lung and where we are not achieving saturations, then probably we might increase. So PEEP should be increased in increments of 2 to 3 centimeters provided the PEEP plat remains at 30. These are some points which we have to remember. So this is a routine flow chart for any ARDS patients. It's a similar one. Patient who intubated appears to have moderate to severe ARDS, then we have to optimize on ventilator for 12 to 24 hours. Attempt recruitment. So what is recruitment? So we'll come to know, I'll let you know. So diuresis if required if there is any volume overload because of too many drugs which are flowing in IV form. So there can be a volume overload, so we have to check the cardiac status too. And if there are any pleural effusions or any effusions, we have to drain them, which hinders the oxygenation. So if the patient is still struggling, then probably we have to paralyze and probably choose prone ventilation. So what is refractory hypoxemia? So in spite of properly ventilating and giving sufficient oxygenation, FiO2 to 80, 100, still the oxygenation doesn't improve, then we call it as refractory hypoxemia. So there are certain points we say, to say that refractory hypoxemia, that is PaO2 less than 60 and PF ratio less than 100. This is typical for refractory hypoxemia. So how should we approach these patients? Because most of these patients are ventilated patients with COVID are of refractory hypoxemia, most of them. So we use neuromuscular blockade, completely paralyze, knock them off so that they don't fight and struggle against the ventilator. Second, prone positioning, which has proven literally, one of the best maneuver during the COVID, awake proning as well as patients who are ventilated, routine proning is good. And some recruitment maneuvers we do, I'll show you. And inhaled nitric oxide we don't practice here, and HFOV we don't practice here. And ECMO, yes, we have the largest number of ECMO and ECMO patients. We have an ECMO center here and ECMO ICU exclusive. So during the peak COVID time, we used to have around 28 ECMOs running simultaneously. So neuromuscular blockade, we use it to completely knock off the patient so that patient doesn't breathe spontaneously and doesn't fight against. Because if we start fighting against, he develops large tidal volumes, which is not good for the patient. We choose low tidal volume ventilation. So muscle activity is reduced, so decreased oxygen consumption is also there. So that's the advantage. There are disadvantages, yes. Post critical care illness might be developed, and also neurological assessment will be difficult, and they develop neuropathy. So recruitment maneuver is nothing but transiently we increase the transpulmonary pressure, the pressure inside the airways and to the alveoli, aiming to open up the collapsed alveoli. So there are generally it is an intermittent one, or sometimes sustained we give. Mostly we choose intermittent recruitment maneuvers. Application of pressure higher than the normal breath for a short period, like for 40 seconds. So they try to increase and then they leave it. So there are two techniques they use. And regarding the prone positioning, in what way prone helps us? it's a multifactorial advantage is there. So it, the diaphragmatic motion is little better in prone position, and increased the functional and residual capacities, they do improve, and there is a better ventilation and perfusion, and also the secretion clearance would be better in prone. But it has its own disadvantages too. Patients develop, crush injuries, and patients develop sometimes, there is a chance of cardiorespiratory arrest, especially the cardiac arrest can happen in prone position if the, properly we don't check the 2D echo and then put them on prone. So 12 to 16 hours of prone is the average time which we use. So in COVID patients who are ventilated. So regarding ECMO, ECMO is nothing but exposed where we use like veno-venous or veno-arterial. We say in COVID we choose veno-venous. Okay, so ECMO itself is an entirely different topic. I can't give you complete picture how it works. And second, patients with hemodynamic instability, then we have to go for veno-arterial. So ECMO is another question for you for the exam. This is just a brief description. We start with low flow nasal cannula, then we go with HFNC. The disease keeps on progressing, might need invasive ventilation and prone positioning and ECMO. That's a bad try, bad way of approach. So iteration. Sometimes they come out of it. So when we come out also, when we put them on ECMO, we try to wean them off ventilation early. If required, tracheostomize and make them more, we mobilize them, make them sit, we awake. We do awake ECMOs also here. So regarding the complications of acute COVID, these are all immediate complications. I don't want to tell you in detail. You might have seen thromboembolic phenomenon, the lung, the pulmonary embolisms, the DVTs, the strokes, myocardial infarctions, arrhythmias. You name the organ and the COVID have started affecting it. Acute kidney injuries we saw, diabetes in apparently young male or young female. So endocrinological issues we have seen, GI complications we have seen. So pancreatitis, there were, the liver enzymes getting raised, amyloiditis is there, transamyloiditis. So all these complications are there. But I want to show some pictures which we saw, the complications. So can you identify? Yes, biliary emphysema. It is a pretty common thing in our setup. We have seen that at least, in 100 patients, at least 4 or 5 patients landing upon biliary emphysema and pneumothorax. So we started putting drains. If you can see, this is the drain. I'm not sure whether it helped the patient or not, because I saw like 70% people getting better after putting the drain, and I saw some people, dying. Not because of the drain, but probably because of the disease. So whether it is useful or not exactly sure. No one describes about putting a drain in the, in the mediastinum in any of this literature and all. And in the X-ray, you can see the CT tomograph, you can see the drain, how it goes up along the heart. But we don't have an option. That's the reason we were trying to, do something for the patient. And here we can see there is a pneumothorax. This patient was referred all the way from Guntur, okay, for pneumothorax and post, during, like he was on 7th or 8th day of treatment for COVID, and he was very breathless. Then we tried putting the tube, we waited for 6-7 days, he didn't improve. He landed up with, recurrent pneumothorax on the same side. Then we asked our thoracic surgeon for the, the BPF to close, and they have done that successfully, and they have sent the material for testing. It turned out to be Cryptococcus. Yeah, these are all surprising things for us. Our pathologist identified it saying that, sir, there is Cryptococcus in this patient. And fungal pneumonias, Aspergillus, you might have seen lots of them. I want to see this number. I want you guys to see the number. Can you see the number? 36 years. Can you identify, though you are pulmonologists, can you identify there is something different right in the brain? One part of the brain is one colored and the other part is different. Can you see? Half of his brain is gone. That's a stroke, acute. We lost the patient. And this is another young male, bilateral sinusitis, filled up sinuses. So they chopped off his maxilla so that, because of mucor. So that's how it was in a 3D presentation of his skull. So the patient is on, line stool for the last 2-3 months. And this is another patient. There was complete lung collapse. This patient presented with, COVID pneumonia with pancreatitis. So he was there with us for 45 days. So in between, he developed complete collapse of his lung when he was on, mechanical ventilation. Then we had to remove the clot. This is how it was. We used cryo in removing the clots. The typical bronchial reappearance was there. This is how the lung of an ECMO patient looks. Can you see anything? Can you differentiate between heart, lung, or anything? This is how they look. Can you see the cannula at least? That's a large cannula which we put. That's an identification marker for ECMO patient. So before I conclude, I want to point out something. Solidarity trial of WHO is coming up with 3 new drugs. Probably they might launch in the next few months. They are artesunate, which we use for malaria. Second, imatinib, which we use for some cancers. And infliximab, which we use for rheumatoid arthritis treatment and some other autoimmune diseases. In our center, we used a lot of infliximab when compared to tocilizumab. So I'm not exactly sure because we didn't do any comparative trials or comparative studies, but we could see that most of our patients got better when we used infliximab when there was a severe shortage of tocilizumab. So particularly why did you use, I can't answer because that was the drug and it was in first wave which we used. Second wave we stopped everything when the guidelines started coming out. This is briefly about what challenges we faced during the acute COVID. Anyone using methylene blue, you can throw some light, sir. Because I didn't use much, but
we have used methylene. So we have used methylene blue in a lot of our patients actually who required oxygen and AV and HFNC. Methylene blue acts at host receptor pathway actually. It's a hypothesis that patients with COVID have a bradykinin storm. Right? Bradykinin stimulates the bradykinin-2 receptor, which leads to vasodilatation, edema, plasma exudation. So when the bradykinin stimulates the P2 receptor, it also leads to stimulation of the nitric oxide synthase. So it leads to production of the nitric oxide. So methylene blue is an age-old agent which has also been tried in septic shock actually. It prevents the nitric oxide release and synthesis actually. So that was used in our patients and we have seen, we have done a comparative study of 3 groups actually, which was sent for publication. We have seen that methylene blue definitely reduced the duration of the like ICU stay and the time it's required, the required oxygen. And then subsequent to that, actually we have done an analysis of bradykinin in our patients actually. So we have seen that in moderate, patients who are having moderate and severe COVID, in both the subset of patients, the bradykinin was also raised actually. We are trying to recruit some more patients who are in the controls, normal controls actually. So initially we started like methylene blue and then we found that subsequently we did a bradykinin analysis that is also elevated in our patients.
Can you tell for the PGs how much we use, how do we give it?
So methylene blue, we should use it at a dose of 1 milligram per kg body weight. And so typically 60 to 80 milligrams to be given as an infusion over 3 to 4 hours. It should not be used with normal saline because it combines with chloride and leads to precipitation of methylene chloride actually. So it should be used only in dextrose, the methylene blue. And then the important things to remember are try to do a G6PD levels and then rule out G6PD deficiency, then administer Methimazole, not to be given in patients who have pre-existing renal failure. These two things are important things which I felt should. And it should be used in combination with some COX-2 inhibitors. They also have an additive action actually if they are using it. So initially these were all some of the observational studies and some case control studies have shown benefit. But definitely we have found benefit in our patients, no harm with Methimazole. I think definitely it requires a good like quality randomized control to say that definitely it will help.
Dr. Gopi-Krishna, thank you very much for a very lucid presentation. You have a very vast experience, I think. But what has transpired for me is the half-life of truth in medicine was quite long actually. But the half-life of truth in pulmonology and COVID era is less than 24 hours. I see. What is true today is not acceptable tomorrow. And we are going through this phase now.
I totally agree, sir. And sad part.
Thank you, sir. I request Dr. Abhijit. We are very much cramped for the time and we have completely overshot the schedule. So I need to give the sorry for the printing mistake in the process.
Good afternoon, everyone. Respected senior professors, students of various colleges of South India. I am Dr. Ramakrishna, Professor HOD Pulmonology from NRI Medical College. So my topic is post-COVID syndrome and also the multi-pronged care. Dr. Gopi-Krishna has covered a lot of topics on that. I would like to present a different version of this post-COVID state. And our center has managed more than 17,000 patients of COVID and really more than 2,000 deaths we have seen during the last year and a half. So as pulmonologists, we face all sorts of pressures, and as many of you students have been in the center of the treatment of COVID disease. And I have been working as a nodal officer of COVID, presenting it to the government officials as well as managing the show in the hospital with a lot of responsibility, teaching the students and also the non-medical faculty how they have to do it to the extent possible. But it was a great experience for all of us. I'll just go through what our experience are. Now, recently we have been going through the statistics. So why you have all been surprised why I'm talking about these deaths, COVID deaths as on 30th of September 2021. Why I put this slide is there are so many deaths in the world, and you have been seeing the worldometer every day, all the enthusiasts all over the world. We have been peeping through that. So all these deaths, in India more than 4 lakh deaths, and United States more than 7 lakh deaths, and in United Kingdom more than 1,36,000 deaths. You know, this everywhere else, the total number of deaths are they have been shown as of COVID. The post-COVID disease has shown nearly three times more of the deaths than the COVID deaths because of the multiple complications that occurred, and majority of the deaths have not been reported. So why I am telling you, while I was going through the literature for the statistics, I found that that there is a crude death rate in every country. Like in India, it is 7.2 per thousand. So I analyzed the deaths from 1st of January to 31st of March. So you expect a total number of deaths of in a state like Andhra Pradesh, where there are 5 crores of population, we expect a total number of deaths of about 1,50,000, 30,000 deaths per month. They are the norm. So COVID has resulted in nearly 2,81,000 deaths. So this has been information, because the death statistics cannot be modified, and nearly 1,31,000 deaths have taken place both in Andhra Pradesh as well as in Tamil Nadu. So amongst them, they occurred between March 15th and May 31st, within a span of 2.5 months. So that is the reason all these deaths, extra deaths, only 5,000-6,000 deaths have been reported as COVID, and rest of 1,25,000 deaths are because of COVID, post-COVID, COVID-related complications. That is the importance of these deaths. That means nearly 25 times more deaths are because of COVID-related complications, which are over and above the crude death rate. So as expected by the crude death rate statistics of in each country. So that's about this is coronavirus. Everybody knows this is the spike protein. That's the importance. And deaths have taken place because of prolonged COVID illness. So one thing is, patient is admitted in the hospital, so he stays for more than a month in the hospital. He is COVID negative, and because of immediate post-COVID state, prolonged COVID illness, he dies. Immediate post-COVID complications is late COVID or long COVID illness and related complications. And you know that I am not going to the details of that. So there are types of protein: spike protein, membrane protein, envelope protein, nucleocapsid proteins, the different proteins. So by means of spike proteins, it gets attached, so this once to the angiotensin converting enzyme 2 ACE2 inhibitor, there is a change in the spike protein which splits into 2. So the virus gets attached by means of S1 protein, whereas S2 protein, there is a transformational change and which causes fusion, and the virus enters the cytoplasm and replicates. A new virus is produced. And what is most important is, so virus is very innocent. What is responsible for the various diseases is dysregulated immune response on the part of the patient. So it is, nowhere in the literature we see the virus has caused this harm, that harm, but only the dysregulated immune response that has caused so many complications. So this, and the center of this dysregulated immune response is the neutrophil. Neutrophil mediated cytokines and neutrophil mediated thrombotic tendency through the C1 to C9 complement components, and finally resulting in damage to the endothelium and increased thrombosis, which occurs in different organs in the body, not only in the pulmonary capillaries but also in other parts of the body. So I am not going to the details of all this replication, because my topic is just post-COVID complications. And one thing I want to tell you, so you know that virus replicates, the inflammation that occurs through the neutrophil. So initially the cellular response followed by the antibody formation, and the IgM antibody forms from the first week of the positivity, and it remains for 2 weeks, for up to 3rd week, and the IgG starts forming from the 14th day, and it lasts up to 3 months after the infection. It may sometimes more, and majority of the vaccines aim at producing the IgG antibodies, which is possibly protective from the further infection, or the complications thereon. So this is the immunopathology. So I summarized in brief in my slides. So it's I think there's not much of a time in describing this. So what I just want to tell you that there is what is described as a neutrophil extracellular traps, which this neutrophil can enhance the inflammation and cause extensive damage to the lungs and other organs. And these particular neutrophils can also contain the inflammation and can stimulate the cytokines from the Th1 clone of lymphocytes, CD4 lymphocytes, like namely the tumor necrotic factor alpha and gamma interferon, and reduce the inflammation of the part. Majority of the people are fortunate enough in that their inflammation is contained, but 2 to 3% of the population are not fortunate enough, and they'll have all the complications that can occur thereon. Defining post-acute COVID-19. So it can be a prolongation of the acute COVID and the thrombotic complications as well as the inflammatory complications continuing and causing extreme hypoxia, and that can result in death also. And post-positive test for COVID-19 is not a prerequisite for the diagnosis. So by the time these complications do occur, the patient can be COVID negative. So that you have all experienced during your 1.5 years of experience on COVID. How common it is. So around 10% of patients who are tested positive for SARS-CoV-2 virus remain unwell beyond 3 weeks, and a smaller proportions for a month. So this is on the UK studies, whereas the American studies say that 65% of the people come back to their jobs normally and after 14 to 2 to 3 weeks, and there are 35% of the people are not fortunate enough, and the seriousness of the disease varies in different individuals. Why are some people affected? Why others are not affected? This question commonly enters our mind. So because of the dysregulated immune response that occurs among patients. It is not known why some people are affected while others are not affected. And what are the symptoms? So even so-called mild COVID-19. So one can have post-COVID problem. So if a person can have a mild COVID disease and can still have post-COVID complications. And a person can have a severe disease and at the same time he may not have many post-COVID complications. So these two are, usually they may not be connected. So even if with mild COVID also, patient can have long complications of COVID-19. Other reported symptoms, cough, expectoration, they can occur. Other reported symptoms are shortness of breath, chest pain, headaches, neurocognitive difficulties, muscle pain, and weakness. So it is very difficult for the physician to really estimate whether the symptomatology of the patient is going to be a serious illness or just because they belong to a psychosomatic symptoms. So they can be, the physician has to decide whether how deeply he has to investigate this multi-systemic disease. So it can be simple, patient may be having a simple problem of breathlessness, or maybe having a psychologically depressed, he may complain of a lot of symptoms. And they can have, because of some amount of fibrosis, he can have some cough or expectoration. But seriousness of illness has to be gauged by the physician by one-to-one talk to the patient and examining the patient with empathy. Next. And they can have some other symptoms include gastrointestinal upset, rashes, metabolic disruption, thromboembolic conditions, depression, other mental health conditions, skin rashes, and can take many forms including vesicular, maculopapular, urticarial, etc. So these are multiple, it's in the hands of a general practitioner to check the temperature, heart rate, rhythm, blood pressure, etc. All the routine things have to be examined, and then so he has to take depending upon the seriousness, you just cannot bring out a list of the investigations, but how deep one can go depends upon the symptomatology of the patient and how serious are the symptoms. It has to go for liver function, troponin, C-reactive protein, creatine kinase, D-dimer, etc. So the patient has got a responsibility in measuring the daily pulse oximetry, attention to general health, rest and relaxation, etc. And medical management, symptomatic management has to be done for cough or breathlessness, whatever it is. But each symptom has to be examined in detail, and to what extent this particular system is responsible for the illness. So another important part, post-COVID state has to be diet, a proper diet has to be maintained, high protein diet, good sleep, has to quit smoking, limiting alcohol and limiting caffeine. What are the post-COVID symptoms? Post-acute COVID-19 symptoms vary widely. Even so-called mild COVID-19 may be associated with long-term symptoms. So post-COVID, what are these post-COVID complications? Post-intensive care syndrome, venous thromboembolism, cardiovascular complications, acute kidney injury. I think Dr. Gopi Krishna has mentioned in detail, acute liver injury, neurological complication, post-COVID syndrome, long COVID, cardiac arrest can occur, and septic shock, disseminated intravascular coagulation, acute respiratory failure, cytokine release syndrome, pediatric inflammatory multisystemic syndrome, thrombosis with thrombocytopenia syndrome from vaccine, and pregnancy-related complications, aspergillosis, mucormycosis, pancreatic injury. So the autoimmune hemolytic anemia, immune thrombocytopenia, subacute thyroiditis, gastrointestinal complications. Post-COVID symptoms and management, so fatigue, difficulty in thinking, in concentration, difficulty in breathing, cough, painful joints and muscles, chest pain. So all these different symptomatology can be listed out, and they have to be tackled on the basis of the importance of the symptoms. So sometimes a specialist has to go in detail in investigating these symptomatology. They cannot be very simple. Sometimes a serious respiratory disease can be there, like pulmonary thromboembolism because of the thrombotic tendency, a CTPA, and serious investigations have to be done like that. Dizziness and standing. So post-COVID complications are due to treatment of COVID also. They can occur because long-standing stay in the hospital because of intubation, oxygen toxicity, pulmonary fibrosis, tracheal injury and tracheal stenosis. They are all being seen in our post-COVID OPD now, and oxygen dependence. So that's also very, when a person has come to our hospital, like who was a very who was very normal person, who was capable of doing a lot of things with strength. But this particular man, just 42 years old, is dependent on oxygen. So this is a very depressing thing for him. So diabetes mellitus can occur. Post-COVID diabetes mellitus is seen in a young individual of 25-26 years age who are probably having tendency for developing diabetes because of family history or the sedentary life. So after COVID, because he received corticosteroid therapy, diabetes is established, and complications can occur. I think it take 5 or 10 minutes more I have to take because a few things are there. Pulmonary complications are very important. Post-COVID, because of corticosteroid, tuberculosis is seen. One because the tuberculosis treatment by NTEP was not being performed properly during this COVID pandemic. Patients are coming now with both pulmonary and extrapulmonary tuberculosis, and decreased DLCO is seen, and because of pulmonary fibrosis associated. One positive thing with COVID fibrosis is most of the patients, even with 21, 22 out of 25 CT scan changes, are recovering and they are improving. But still some people are behaving like respiratory cripples with the problem. So most SARS patient is fibrotic, had similar fibrotic changes in the lung, and anti-fibrotic agents in the form of nintedanib and pirfenidone are being tried now. So long-term results are required. And post-COVID tuberculosis is seen now, and post-COVID mucormycosis is seen. So because of probably hyperglycemia and poor treatment of diabetes, a new onset of diabetes, prolonged ICU stay, and pre-existing comorbidities. So mucormycosis is being special importance by the government of Andhra Pradesh as well as Telangana. So a lot of and government is instituting treatment for such patients. So this is the mucormycosis lung. And cardiac complications, I think cardiologists are there around. So during the acute COVID also, we have patients with elevated tropoid and chronic patients with dilated pulmonary vessels, pulmonary thromboembolism are seen. So maybe some unexplained breathlessness among our patients. So post-COVID state with elevated D-dimer levels. So CTPA done, not all the patients had associated pulmonary thromboembolism with the large vessels. Some people had small vessel thromboembolism. So we had to resort to giving anticoagulant therapy, despite the fact that the large vessels do not have the endovascular thrombosis seen. Cardiac changes by echo, dilated left main coronary artery, left antedescending artery, left circumflex artery, diffuse coronary ectasia, and severe coronary ectasia are seen involving both right and left coronary arteries. Post-COVID heart disease and myocardial infarctions are common because of the thrombotic tendency. We find patients post-COVID state elevated D-dimer levels even 2 to 3 months after the treatment of COVID. So then severe COVID disease affects the endothelial cells because of the inflammation, and multisystemic inflammatory syndrome is seen in children. So these are involving the multisystems, and multisystemic inflammatory syndrome in adults is not that well signified as in the case of children. So these are all the complications presenting with shock, rash, abdominal involvement, acute kidney injury, and only 32% having respiratory symptoms. So the multiple ways they are treated multisystemic inflammatory syndrome. So you have to investigate in a similar way for the various inflammatory parameters. And post-COVID kidney disease is common because of glomerulopathy. So this can occur because of direct viral injury as well as thrombotic tendency of the vessels. So it can result in collapsing glomerulopathy, podocytopathy, crescentic glomerulonephritis, and a lot of other things. Probably nephrologists are aware of such things. Post-COVID liver injury, means direct liver injury, or because of the vascular changes and liver failure is reported, particularly obese and diabetic individuals. Because chronic liver disease is associated with immune dysregulation and inflammation, it is unsurprising that patient with chronic liver disease may carry a greater risk of adverse outcomes from this virus, SARS-CoV-2 virus. And then post-COVID depression and aggravation of psychiatric abnormalities. This is a very common thing because COVID is associated with the loss of job for many and loss of loved ones. And the second wave, we have seen many of us also lost a very close kith and kin, and because of that because of loss of the spouses, so the families are disrupted totally. It is natural that there is depression gets aggravated, and psychiatric abnormalities, financial loss, loss of loved ones, loss of profession. So that is seen with many because post-COVID hair loss due to a alteration of hair cycle, acute telogen effluvium. So that is seen post-COVID reproductive complications. So this is, this is not, it cannot be exaggerated because no authentic observations are seen. And syncytin protein in human sperm resembles spike protein, and antibodies to spike protein can interfere with the fertility and implantation. Though the number is not seen, but the studies suggest that there is a possibility. Long studies are needed in that, and COVID virus is seen in placenta. Those people who develop COVID virus disease are after vaccination. It is seen in the placenta. Transplacental infection is reported to infants, and in the male, testicular ACE2 may regulate testicular function. So COVID virus can enter the testis, and it gets attached to testicular angiotensin converting enzyme 2 receptor. It can play a function, it may play an important function and sperm's contribution to embryo quality. But and long-term studies are needed to quantify the exact damage that can occur because of that. SARS-CoV-2 enters the cell by binding to ACE2 receptor. Principles of COVID vaccination: COVID vaccination, we have to, those COVID affects people who are vaccinated once, who are vaccinated twice, and this among such patients, so those people who have received antibodies, so those people who received plasma, the second dose can be postponed. So I will conclude within a short time. There are not many slides left. So I think for students, certain slides are required. That's why I kept them. Multisystemic inflammatory syndrome can also occur after vaccination. Post-COVID neurological disorder can occur in the form of intracranial hemorrhage, ischemic stroke, Parkinsonism, Guillain-Barré syndrome, narrow root and plexus disorders, myoneural junction, and encephalitis. Dementia, psychotic, mood, anxiety disorders, substance use disorder, and insomnia can occur. Post-COVID illness can involve any organ. Physician should be alert in identifying the seriousness of the symptoms. Everyone will come out with symptoms, but physician should be aware of the seriousness of the symptom, and depending upon the seriousness, each system, whether neurological or pulmonary or cardiovascular, has to be investigated in detail. Multi-pronged approach is needed. This is not a single man's job. So it requires multiple specialties and multiple consultations from different specialists. Long-term studies are needed in understanding the seriousness this particular COVID disease has caused to our mankind. Thank you very much for your patient listening. Thank you very much for giving me extra time.
I request Dr. Bronchiectasis sir to present the slide. We have seen so many diseases, but ultimately it is the rehabilitation which recuperates the patient. So our next talk is going to be on pulmonary rehabilitation, and I request Dr. Sai Pradin sir, consultant pulmonologist, Apollo Hospitals, Hyderabad, to give his talk. Thank you.
Hi, good morning, good afternoon everybody. Thank you Dr. Nada for this invitation. I'm sure you all have empty stomachs or full stomachs. I'll be really fast. And I think this talk might save your life and your patients' lives. So just focus for about 7 or 8 minutes. I'll run through a few slides. I promise you it will be interesting. You may learn a little bit. And today we've had an immense amount of knowledge that has been shared by all the experts and seniors. No conflicts of interest. Now, what is pulmonary rehabilitation? It's pretty simple. It is a boring topic, I understand, but this one is important for your patients. Exercise, education, behavior, these are the 3 things which actually matter. And that's really what PR is all about. It's a comprehensive intervention and it involves exercise training, and it really is about improving your patient's symptoms. And if you really look at it, the exercise tolerance that comes with pulmonary rehabilitation is critical to actually making all your other treatments work. Because it doesn't matter what you do if the patient is not feeling better. And pulmonary rehabilitation has been known to actually make your patients feel better. It is getting popular. If you look at PubMed, the number of articles on pulmonary rehabilitation has been exponentially increasing. Especially in the last 2 years, there's been a large number of publications, including from India, about rehab. This is a concept you may want to know about. You might have heard about MET. A MET is a metabolic equivalent of task. So all of you have been sitting for about 2 hours. So each hour that you sit quietly resting with your mind hopefully awake is defined as the energy expenditure, and it's about 3.5 ml of oxygen that you consume just sitting there. And this is the basic level that everybody actually needs. And as you start doing more activity, as you start walking, talking, doing your treadmill, etc., your MET equivalents keep going up. What you need to also realize is that normal activity is what you're doing at the baseline is not adequate for you to generate a negative calorie balance, which is why you have to do